Well, thanks, Tom. And it's great to be here. And I'm sorry, I'm going to break his heart. We don't have a drug that's going to do what he asks, so we're going to just have to exercise and eat right. So looking at graphs like Gabe presented, I think it's invariable. You look at those lines and you try to find which line am I on, and I looked at the line that I'm on, and it doesn't look good. So as we get a little older, and I think some of it will dovetail into what I'm going to share with you today. So I did develop an outline for this discussion that looks at a couple of aspects of healthcare. So number one, I wanted to offer a current economic lens and the trends that we've been seeing in the United States and in about 10 or 12 other countries, and looking at the outcomes of our healthcare systems. Going to take a look back at the last 30 years because there's been a lot of change in healthcare in the last 30 years, and I think it sets the stage for what's going to happen over the next 30 years. So we'll talk a little bit about that. And I'll spend a minute or two trying to connect it back to construction and impacts of how it might change the construction industry and healthcare. So as we think about healthcare and we talk about GDP, nationally, healthcare is about 20% of our gross domestic product. So it's a big chunk of our economy. If healthcare stood alone as a country, we'd be the 5th largest economy in the world. So that's just the U.S. healthcare. We employ a little over 1 in 10 of everybody that works in our workforce. And about 2/3 of healthcare expenses are paid through federal or state programs, so Medicare and Medicaid. I think right after defense, we're one of the biggest expenses. So I think we all have a vested interest in trying to manage this cost because it's driving taxes. And I think there's different ways to manage that. And then healthcare inflation. I know you've all heard the story over and over. Healthcare far outpaces the consumer price index compared to everything else that we spend money on in our economy. So this is a look back of healthcare spending. This actually goes back 40 years. And guess where the U.S. is? We're leading the pack. So this is healthcare spending as a percentage of gross domestic product. So back in 1980, we were actually in the pack with these other westernized countries in terms of our healthcare spend. But over the next 40 years, we saw tremendous change. So going back 30 years, in 1992, we were spending about 13% of our GDP on healthcare, and that was about $3,300 per individual. Fast forward to 2020, it's up to the 20%, and it's quadrupled. It's 4 times greater, $12,500 per person for healthcare expenses. And again, look at those other countries. We're spending a lot more per person and as a percentage of our GDP than anybody else. So are we getting better outcomes? Well, we'll talk about that in a second. So where does the money come from for our $4 trillion healthcare system? Well, the biggest chunk comes from health insurance, and as I mentioned, the biggest chunk of that is coming out of Medicare and Medicaid and a few other federal programs. You can see out-of-pocket expenses, which I think are increasing, and I bet you're all feeling that, and then other programs that are being developed by third-party payers or Blue Cross and programs like that. So when you think about healthcare, what comes to mind? Top of mind, healthcare. You think of hospitals, doctors, nurses, ERs, ORs. That's generally what we think of. Well, as we look back at that $4 trillion spend, how much of it is spent on this? Well, as you look at this graph, it takes a look at where that $4 trillion goes. So about a little less than 1/3 is going towards hospitals. So over 2/3 are going to other non-hospital-based entities that are basically driving the healthcare economy. A chunk of that is physician and clinical services, likely outpatient. But then there's a gamut of things and other services. And then the big chunk of other, you can see that there's more home health care and residential health care that seems to be evolving. So you're going to see a little bit more of this as we talk about the future. So what do we get for this big investment? So there are a number of groups that have looked at cost versus outcome and tried to compare the various economies that we've talked about. So there's a grid, And it's basically putting health system performance against healthcare spending. And that's where the US is. So we are standing out in expense, as the other graph showed, but this is looking at outcomes of what the system is deriving for a population. So, what are we looking at in terms of outcomes? Well, outcomes are looking at access to care and how efficient our care process is, how efficient our administrative expenses and structure are, the health equity across our population, as well as healthcare outcomes. And I think the outcomes are the things that, I think would point to where we want to make some bigger differences. We have the highest infant mortality rate compared to any of those other countries. And we're looking at just European, westernized economies who have a lot of the same training and access to technology that we have, but the way they run their system's a little different. We have the lowest life expectancy at age 60. So pretty sobering. I think most of us probably will be on the better side of those averages. But as you look at our entire population of 350 million people in the United States, that's what we have to look forward to. And we're last on the preventable mortality measures as we look at things we could prevent that might cause you to die compared to the better running system. So it's like, boy, we're spending a lot of money, and this is kind of where we are. So I think this kind of sets the stage for what we need to do differently in the future. So looking back in the last 30 years, there have been a number of things that have occurred that have been fundamental in changing healthcare. First off, most hospitals were community hospitals 30, 40 years ago. They've all moved into health systems. I can't think of a hospital in Southeast Michigan that's not affiliated with a major national or large regional health system. It's just the way it is. The economics and the cost of running IT and other expensive things really compel you to be in a system that has better access to capital. And a lot of community hospitals have closed. We've seen a wild expansion of ambulatory care. So small buildings, big buildings. This is actually how I got to know AUK. Vince and I met probably 30 years ago on a big ambulatory project. He had thick, wavy, dark hair, and he really was very, very distinguished. And I was handsome myself. So, ambulatory care expansion started to move things away from the hospitals, and we've started to see in my career the percentage of expense coming from outpatient versus inpatient services continue to grow. It's almost 50-50 now. Physicians have migrated to employment. So physicians always ran their own independent businesses, very proud, and they basically commanded their own fate. And they were really bound by the guidelines of their own medical staff and their organization. Well, these first three things, particularly number 1 and 3, we've got community hospitals aggregating into systems, and we've got physicians aggregating into employment. One thing that's going to drive is a lot more standardization. And in this case, and I think a lot of you are engineers, standardization or variation is actually not necessarily a good thing when you're trying to provide a system of care. So variation and reducing variation and really trying to find what are the best courses of treatment and making sure everybody follows them has been a tremendous focus over the last 30 years. And then, of course, what you reflect on the most, the explosion of technology. Laparoscopic and robotic surgery. Pretty amazing developments. I mean, if you had your gallbladder out 30 years ago, you had an open incision, and that your gallbladder is actually pretty deep in your abdomen, that surgery and that recovery is pretty gruesome. Now they take it out with like 4 different scopes through laparoscopy. They can go in and they make small incisions in your body. They go around your organs. They don't cut you up. And you can go home the next day. Whereas before you were going to be in the hospital for a few days and your recovery would be months. So, and robotic surgery takes that to the next level, and the precision that you can exercise with a robotic surgery is quite amazing. It takes average surgeons and makes them spectacular because it enhances their skill. Pharmaceutical changes, I think you're keeping pace with that. Imaging changes and just continued refinement of everything we do, whether it's mammography, digital mammography, 3D mammography. We're just continuing to add and change and make these things better and more precise. Cancer drugs and treatments, a pretty amazing impact we've had on cancer, and we've really made a change in that. And then this last statement, what was quaternary a few years ago is now a community standard. So, 7 or 8 years ago, if you needed an aortic valve replacement, you had to go to one of the university centers or a major medical center to get access to transarterial valvular replacement, I think. But anyway, that was, as opposed to having open heart surgery to fix your valve, they can go in through your groin, through your artery, go in there and take out the old valve and put in a new one. Think about that. They're fishing that through your vein. So 7 years ago, major academic center. Now that's migrating into Main Street medicine. Community hospitals have to demonstrate that capability. So we're also doing a lot more in screening and early detection. I'm sure you all are getting nagged by your families and your physicians about those screenings that you're age appropriate. So very, very important, and it's having an impact on healthcare. Population health and patient-centered medical homes, I think, is an important component where we're starting to, like with an HMOs, incentivize providers and hospitals to keep people healthy, not just wait till they get sick. So I was talking to my daughter 20 years ago when she was a little girl, and she says, well, what do you do every day? I said, well, I run a hospital, and, this is what's there. And I said, by and large, we're trying to take care of sick people, and it's like, we hope more sick people come to us because, we have a very fixed cost business, and, I could have graphed it all for a 7-year-old, but I think it would have been a little lost on her. So she basically, kind of at the end, she goes, so you want people to get sick? It's like, no, we don't want people to get sick. We just want them to get sick. We want them to come to us. Well, we're starting to change that as a healthcare system. We're trying to prevent the illness. Electronic medical records, big advent. And, major renovations in bed towers. So Vince and I would joke every once in a while. If he went to a new town, he'd always say, hey, I can tell where the hospital is. It's where the tower crane is. Constant renovations as well as replacement bed towers. And then something you're also experiencing, I alluded to it before, the shift of expenses, giving the high rate of inflation from just employers and insurers to patients and employees. How many of you are paying higher deductibles than you did 5 years ago for things that you need? Yeah, if I could see it, I'd say everybody. So yeah, big shifts. And you know what? That's impacting healthcare decisions. People are foregoing healthcare because they're going, geez, I don't want to get an MRI. That's going to cost a lot of money. I can ride this pain out a little bit longer. So a quick example of some of the changes we've seen. So if you had a blocked artery around your heart 15, 20, 30 years ago, you probably had a coronary artery bypass graft. And in one of the health systems I work with, the major medical center in 2015, had about a 15-day length of stay for open heart. In 2022, that's a 5-day length of stay. So a lot of different thoughts and theories about what it takes to get better. But if you have open heart surgery today in the morning, you're going to be standing in the afternoon at the side of your bed, because getting you ambulating, we've discovered, is really important. Here's another fact. This same medical center back in 1992 did 2,200 open heart surgeries a year. In 2022, they did 450. So in 2022, we're doing less than 1/5 of what we did back in 1992. And you can see that from a patient day perspective, it's about 10% of the number of patient days that it took to provide that care. So we don't need that hospital capacity the way we did. So why has that changed? Everybody's on a statin to reduce their cholesterol if they have high cholesterol. It's reducing plaque, it's reducing blockages, and people aren't getting treated. Oh, and if you are getting treated, the other technological intervention is angioplasty and stenting. We bring in the cath lab. We have it done in a day, and you can go home that night. So big changes. And then hip and knee replacements. 30 years ago, 5-6 days stay in the hospital. Now it's outpatient. And that's really accelerated over the last 30 years. So, where's the fun in this, right? So, I mean, there's tremendous room to improve. We know we have to and will drive better outcomes. We know we have to bend the cost curve. It's just, we have to do this for our own nation and our own population. So we were going to have to figure that out. IT, huge investments in IT. And I did put this dot point on there. As progressive as we are in healthcare with the miracle drugs, the great treatments, we're the only industry that relies heavily on the fax machine to communicate. So you get the world's best machine that gives you a result, I better fax it to that doctor. So, we're having to catch up on that. So at the starting point we're at now, described a system where we are compelled to drive improvement. One of the issues we have today, though, is we've kind of gone through this pandemic. And it's wreaked havoc on many aspects of society, and particularly hospitals and health systems. It's exponentially increased our labor cost. So hospitals run on skilled labor. How hard is it to find skilled labor? So imagine that we're in 22 states, and every health system we talk to is having the same problem. The cost is out of this world, and we can't find the people if we can, even if we can afford to pay them. And then we're also seeing depression in the number of patients coming to the hospital, which means in a very heavily fixed cost business, our volume and revenue is way down. So you look at major health systems across the country, we're talking billion-dollar losses. That is not sustainable. Now, most of these are probably 20%, 25% operating cost or operating losses and 75% portfolio losses. But when you record it on a balance sheet and try to flush it through your income statement, they're huge losses. And my company, Trinity Health, is in the same good company here. So obviously that's not sustainable. And the pandemic is compelling us to do some things differently. So there's a number of different think tanks that have taken a look at what's going on and what they predict is going to happen. And I actually was going through the McKinsey material. I thought it was succinct, but the themes are all very similar. So there's 10 themes that McKinsey would call out. Personalized, transparent, and patient-centered care. Well, what does that mean? Well, we're investing heavily in EMRs and things and trying to create tools that are not just good for the hospital and the doctors, but some things that patients like to use. How many of you have ever accessed test results through a patient portal? I mean, that's becoming the norm. And if you can't get a patient portal, you get a little frustrated. Virtual care and telehealth is really starting to take off in just about every setting, whether we're trying to use it in the hospital, when we're using it in ambulatory centers, or you don't even leave your house. Increases in ambulatory care for lower acuity patients, and as I mentioned before with knee surgery and hip surgery, the definition of low acuity is constantly expanding. Home health care is really huge, and then shifts to more value-based care models where we're actually paying physicians and hospitals to prevent illness, not just treat it. So it's a giant shift. We've been doing this kind of toe-dipping it for the last 30 years, but I think it's really going to take off. And how many of these things are we experiencing today? All of them. So as we look at, the next 5 big things, you see the relationship. Data and technology is probably embedded in most of these. Price transparency and data interoperability. If you have a CAT scan in Traverse City and want to get followed up on here, 10 years ago, they'd have to redo your CAT scan. Well, now we can share the image between the 2 health systems, so we can reduce that cost. I'm wearing an Apple Watch. It's the first generation, so it's kind of old. It still takes my pulse and will do an EKG. So, we're just starting to see. Now, imagine these things starting to embed it more and connect more with other aspects of healthcare. So, which of these things are we experiencing now? All of them. And I think to think any one of them is going to drive and make the huge difference, I think it might be a little naive. I think all of these things working together and finding providers that can put them into play and leverage them, we're going to see a tremendous suppression in healthcare construction, at least in a traditional sense. So what I would argue is that hospitals are not going to be the base of healthcare spend. Hospitals will stay around, will take care of the most acutely ill, every hospital is going to be akin to an ICU because you're going to be that sick to be in there. And another good example too, the type of things we do in hospitals will change. So we're installing a new electronic medical record across our 100 hospital health system. We have a cabling and IT infrastructure project at one of our regions, a 3-hospital region. It's $140 million in just IT infrastructure and cabling to prepare us for this other expensive EMR. So there is construction work, but it's going to look a little bit different. Ambulatory care will continue to grow and evolve, and I think this technology will find its way into the ambulatory care settings. And you know payers are going to push, the insurance companies are going to push patients to be taken care of in these lower cost settings. And then finally, hospitals and health systems are going to continue to diversify services. So there's a $4 trillion spend in this country as of today. We're looking at whether it's skilled nursing or assisted living or home health. We're continuing to try to diversify our portfolio. So there's a lot on the horizon. I think as you hear some of the other speakers, there's references back to healthcare and the aging population and demand, but there certainly are a lot of things that are going to impact the way we provide care and prevent illness. So it is an exciting time. I'm excited to be a part of it. I'm excited that I'm going to retire in 5 or 6 years. But at the same time, it's really going to be fascinating. And preparing for this discussion got me a little more excited about what we can do to make a difference. So with that, thank you very much, and we'll see you a little later.